Okay. So sorry. So we'll be finishing up topic 4 with this video. Actually, with there's going to be two parts to this to this lecture. So this is the first video to finish up topic 4. Topic 4 being blood. Okay, so when we stopped, we were on white blood cells, which are also called leukocytes. And in this image, you can see this is what's called a blood smear. Hopefully, you guys are looking at this in lab. And you can see in this image all the different types of blood cells. So, the majority of these guys, the red-looking ones, are red blood cells. And then in addition, we've got these. So red blood cells have no nucleus. They're very uniform looking. And then we've got these big guys, sort of more normal looking cells. They have nuclei. So these are the white blood cells, these bigger ones, pretty clearly distinguishable from red blood cells, right? You also find in a blood smear, you can see these little guys here. These are actually a bunch of little cell fragments called platelets, and we'll come to those a little bit later. For now, we're going to be focusing on the white blood cells. So white blood cells are so unlike red blood cells, they're very typical kind of active cells, and their role in the body is immunity. They are the cells of the immune system, so they're responsible for identifying and destroying foreign organisms or foreign material. So like if you get a splinter and you don't get all of it out, so white blood cells can actually go and basically break that stuff down and remove it from your body. So white blood cells are very mobile. They undergo what's called amoeboid movement, and so we saw this image when we were talking about how red blood cells get destroyed, and we said, this guy here. Where's my little pen? This big old cell is what's called a macrophage, and he crawls around like an amoeba throughout the body, looking for things that need to be consumed and destroyed. And so the macrophage is one of the. It's actually a white blood cell that actually has moved out into the tissues. So it's got a different name when it's in the blood, but it's basically the same type of cell. This is what white blood cells do. They crawl around and they eat things up and they destroy things. And so, in fact, they one thing that happens a lot with white blood cells, they're blood cells, meaning that they're obviously found in the blood, like this, but then they're constantly kind of scanning the blood for foreign molecules that they can recognize. And when they recognize foreign molecules, usually those foreign molecules are coming from infections that are not in the blood but are in the tissue outside the blood. So when they recognize things that they think they need to, basically respond to, what white blood cells frequently do is they leave the blood and go into the tissue. So there's sort of several steps of the process, and I don't really want you to worry about the individual steps particularly, but they'll recognize their molecule, they'll come and adhere to the wall, and then there's this term, this is kind of an interesting process called diapedesis. So the white blood cells are pretty big, and the spaces between the cells of the wall of the capillary, there aren't very, very big spaces here. So you might wonder how the white blood cells can get from the blood into the tissue, but they can squeeze themselves through these narrow little holes in the capillary wall. And that process is called diapedesis, and they use that to basically go from the blood into the tissue to go attack whatever it is. And so if you've ever seen pus, Pus is basically a collection of a whole bunch of white blood cells that have left the blood. They've gone into the tissue to attack something, and pus is basically just a big collection of dead white blood cells. Okay, so let's talk about the different types of white blood cells. Hopefully you guys are going over this in lab as well. There are 5 main classes of white blood cells shown here. 3 of these fall into what we call granulocytes, and they're called granulocytes because in a microscope they look like they have little granules in them. Those granules are in fact vesicles, and we'll talk about sort of what those vesicles are about in just a second. Okay, so we got 3 granulocytes, and then you've got 2 types of agranulocytes, so cells that don't have, obvious granules. Okay, so we'll start with the granulocytes. So, basically their function is kind of fairly similar. They're used for slightly different reasons we'll talk about, but in general, so they all have these granules, which are vesicles. So they're full of these little vesicles, and basically what they do is when they detect the thing that they need to respond to, they go to the site of an infection, and then they release their vesicles through exocytosis. The vesicles contain some kind of noxious chemical or chemical signaling molecule that helps fight the infection. So these, say a neutrophil. Neutrophils are full of basically toxic chemicals in their vesicles. And so when they detect an infection, they go to the site of the infection, they release all those vesicles, and those toxic chemicals get released onto, the invading organisms and hopefully kills them. And all the granulocytes basically do the same thing, but they have somewhat different functions. Okay, so starting with the neutrophils. Neutrophils we kind of think of them as being sort of the infantry of the immune system. Okay, so first of all, they are the most common type of white blood cell of all. So if you take all the white blood cells, all the different types of white blood cells, all 5, you find that by far the most common is the neutrophil. Okay, and you can kind of observe that. So in this smear, this is kind of a typical smear, and you can see that we've got 4 white blood cells in this image, and 2 of those are neutrophils. Neutrophils are just the most common thing to see. So there's lots of them. They're generally the first cells that respond to an infection. So neutrophils detect the presence of an infection. They march out to the site of the infection. They release their toxic granules, and they hopefully damage or destroy the invading organisms. Okay, so they're the first line of attack. Eosinophils are named for the fact that they have red staining granules. So the red dye in a blood stain is called eosin. So they take up a lot of the eosin in their granules, and they look very red. Not very many of them overall, but so again they have vesicles, and the vesicles get released, and when the cells get activated, get triggered. Eosinophils have kind of a particular function in that they're specialized for responding to parasitic infections. So, someone comes in and they're having, belly problems, pain and diarrhea, say, and you suspect they might have a parasitic infection. One thing that helps make that diagnosis is you take a blood sample and you count. One of the things that's often done clinically is to take a sample of blood from a patient and count their proportion of different types of blood cells that they have. And normally the eosinophils would be pretty rare, just 1 to 4%. If in this patient who you think might have a parasitic infection, you find that eosinophils are 10% or 20% of the total, they have a significant elevation in their eosinophils, and that suggests that you might be correct about them having a parasitic infection. Now, it's not the greatest test. Parasites don't always cause increased eosinophils, and increased eosinophils can be found in plenty of other things besides just parasitic infections. But it's a piece of evidence you can use. and they are particularly responsive to parasitic infections. Okay. Basophils, the name refers to the fact that they take up the other type of dye stain that's used in blood staining it's called a basic stain. So they're basophils. They like the basic stain. The basic stain is blue, so these cells have very dark blue granules. You can often not even really see the nucleus very well. Tend to be quite rare overall, only about 1% or less of the total. So these guys, they can detect the presence of an infection or some foreign material, and then they get activated. They release their granules, but the granules of basophils actually don't function. They don't help fight the infection, or they don't help fight the thing that they're responding to. Instead, basophils, so the granules of basophils, I should say, the vesicles, are, when they release those vesicles are filled with chemicals that actually trigger inflammation in the body. So basically, the role of the basophil is to increase inflammation in response to an infection. So, and not just an infection, really, and so basophils can respond to things that aren't just infections. So, for instance, like poison ivy, is an example of. So, as a chemical released by a plant that triggers basophils, causes them to release their little granules, and those granules cause an inflammatory reaction, which includes, swelling, redness, increased blood flow. So, the reason we get inflammation is it basically increases blood flow. It stimulates a lot of the other immune cells. And so, if you have a real infection, it's helpful to have your basophils come along, release their granules, stimulate blood flow, stimulate immune cells, increase immune response. But, basophils also can respond to things that there's really no reason for your body to respond to them. I mean, poison ivy, the chemical isn't going to hurt you, but the basophils think it is, so they go and they respond. They release their little vesicles and they make all this inflammation, and now you're in agony just because your stupid basophils don't know the difference between, poison ivy and a real infection. So, people who have. There are people who just seem to have sort of excessively active basophils, or sort of the inflammatory system overall is too active, and partly that's due to their basophils. And one example, one of the chemicals released from basophils is called histamine, and I'm sure many of you are familiar with histamine because there are lots of drugs that are sold out there for blocking the effect of histamine. So antihistamines are drugs that can block the histamine released from basophils and prevent that histamine from triggering inflammation. So, people who have allergies kind of have to block the effect of their basophils by taking drugs to block them. Okay. Let's talk about the agranulocytes now. So the most important agranulocyte and the second most common cell of the immune system overall is the lymphocyte. So we said how the neutrophil is sort of like the infantry of the immune system, right? The first to respond. It does basically just throws itself on the enemy. Sorry, I had to pause there. What was I saying? So, right. So we say that, the neutrophils are the infantry, right? The first to attack. So then the lymphocytes we can kind of think of as the generals or the intelligence system. So they're the ones that basically determine what does and does not need to be attacked, and then they kind of send the signals out to kind of coordinate the response and basically bring a bunch of immune cells to the appropriate location to mount a response to try to fight off the infection. So one of the main ways lymphocytes do that is that they release signaling molecules that then go out and signal and basically tell all the other immune cells what to do. And the main type of signaling molecule that they release is what's called antibodies. So when you get antibodies are molecules that are able to basically detect something as being a foreign organism versus something that's like part of our body. So antibodies are responsible for distinguishing between the good things and the bad things, and antibodies are made, synthesized by lymphocytes, and so lymphocytes, and so like if you get an immunization, so you get injected with some, say, flu particles, and the way your body becomes immune is that the lymphocytes see those flu particles and make antibodies against them, so that if you get then a flu infection, you'll have a lot of antibodies that were made by the lymphocytes, and those antibodies will trigger a huge immune response and should hopefully prevent you from getting sick. You'll kill the virus before it makes you sick. Lymphocytes have a pretty large nucleus relative to. So their nucleus is big relative to their cytoplasm, and the nucleus, of course, is needed for making proteins. And so this kind of shows the fact that these cells make lots and lots of protein, so particularly antibodies and other stuff too. And so, so one illustration of the importance of lymphocytes is that the loss, if you're going to lose any one type of white blood cell, I would say lymphocytes are the ones to choose. Losing neutrophils is bad because they're very good at fighting against infection. But losing lymphocytes, I think, is generally even more devastating because you just can't even mount a response at all, basically. And actually, to demonstrate that, so there's a virus that selectively attacks and kills lymphocytes called HIV, and in fact, HIV doesn't even kill all your lymphocytes. It only kills one subtype called the T cells. But, as we all know, so HIV, which kills, one type of lymphocyte, leads to extremely horrible series of disease processes, which we call AIDS, and so just the loss of one type of lymphocyte can basically devastate your immune response. So even though you're not losing a ton of cells, they're so critical to the process that if they don't work right, then you have severely impaired immune system. Okay, and then finally we have monocytes. So these are these big cells, and there aren't a lot of them there, but there's a decent number. I guess they're the third most common. So when you think about this, like cells crawling around, eating things up, that's really the monocytes' job. Okay, the granulocytes, they go more and they release their vesicles on stuff and try to kill them, but the monocytes are the ones that actually go and engulf stuff and eat them up. And in fact, you may have heard the term macrophage. We talked about, in fact, macrophages here, right? That guy there is the big guy. There's a macrophage. So the macrophage is just the name that we give to a monocyte after it leaves circulation. So when a monocyte, goes and leaves circulation and enters tissue, its name changes and it becomes a macrophage. And macrophages are the cells that crawl around in the tissue and engulf and destroy things. And it's just the same cell as a monocyte, but just a different name. Okay. Okay, so let's talk about platelets. Platelets are actually little fragments of cells. They're not actually cells at all. They're just membrane with a bunch of, so here's kind of a diagram showing what they look like. Membrane with a bunch of vesicles inside. So there's no nucleus or anything. so they float around in the blood, and they're filled with these little vesicles. And their job is to prevent blood loss, to help prevent blood loss. And they have sort of three things that they do to do that. We'll talk more, we'll really go through this more carefully in a bit, but just sort of a brief overview. So the first way that platelets can help prevent blood loss is that they can make what's called a platelet plug. So basically, if you get a small break in a vessel, just like if it's a pretty dinky little break, you actually don't need to make a whole clot to close that off. Instead, the platelets can come and sort of stick onto that break, and they sort of grab onto each other, and they make a plug that seals off that little break. Okay, so that's the first way that platelets help prevent blood loss. The second thing that they do is that they can, if there's a bigger break, if there's a break that's too big for just a platelet plug to handle, they actually can help initiate the formation of the big, chunky thing that can, really block off a vessel break, which we call a blood clot. So a blood clot is formed. So here's kind of a really extreme close-up of a blood clot, and we'll talk more about blood clots in a bit. But a blood clot is basically a big network of protein fibers, and it's formed to seal off bigger breaks, and platelets can help trigger the formation of a blood clot, as we'll see. The third thing platelets do to help prevent blood loss is that so when a blood clot is made, in any blood clot, so you can see the protein fibers of the blood clot, but there are some red blood cells that get trapped in the clot, and then also a bunch of platelets are also sort of within the clot. So the platelets in the clot actually have a pretty important function. So what we're looking at in this little experiment is, so initially this is basically a blood clot that they formed in a tube, and this is the plasma before the blood clot forms. This is the plasma when they put an object in to help basically just triggers a clot to form. So you get clotting, and this is the clot. But what you find then is that after that clot is initially formed, what happens is the clot contracts, or what we call actually clot retraction. And what's going on here is that the clot basically is contracting. It's getting smaller. And the reason that happens is that the little platelets that are basically embedded within the clot, they have some proteins inside of them that can cause a contraction, and the proteins are actin and myosin. And hopefully those are familiar to you from ANP1, where you learned about muscle cells. So muscle cells have actin and myosin, and they use those to contract, right? The muscle cells contract when myosin is activated to pull on actin. So actin and myosin are used to allow a cell to contract. Well, platelets have actin and myosin as well, and when they are basically activated within a clot, they turn on their little actin and myosin, so all the little platelets contract, and as the platelets contract, the entire clot also contracts in what we call clot retraction. And what that does is, so imagine you have a pretty significant break in the skin, say, then you get a blood clot. What you'll see is that the blood clot, if you could monitor the blood clot would form, and then the clot would shrink, and what that shrinking does is it helps pull the edges of the tissue closer together to make it easier to heal. Okay, and also to prevent, to reduce the chance of the vessel breaking open again. So it helps kind of put compression on the vessel, and it helps bring the tissue edges together to promote healing. Okay, so platelets kind of have those three functions in helping prevent blood loss, and we'll talk more about that. Actually, we'll go in sort of more detail on those steps in a bit. So what we're going to talk about next is what's called hemostasis. Hemostasis is basically the fancy word for stopping blood. These are so we have hemostatic processes in our blood whose job is to prevent blood from flowing and basically blood from leaking out, when there's a damaged vessel. And these are really, really important for our health and well-being. We experience small vessel breaks all through our bodies, mostly on our external surface, so our skin and and mucous membranes, but also in our internal surfaces, so like all throughout our digestive tract and our our urinary tract and everything. We get just little tiny injuries, little vessel breaks, and it turns out these vessel breaks can actually be really problematic for people who don't clot very well. You will see what kind of things that can get. But even more important, large vessel breaks are not uncommon, both external, if you get a wound, or internal, if you have, say, and you get in a car accident and you break, you injure an organ and it's bleeding, and the clotting mechanisms are really critical to survival in those cases. People who don't clot well can very quickly die from significant vessel breaks because of blood loss. So we've got a series of mechanisms called hemostatic mechanisms whose job is to stop blood from flowing out when there's an injury, when a vessel is broken. But it's a really, really delicate thing, and clinically, it becomes a really, really complicated problem because you've got these. So obviously, blood normally needs to be liquid, needs to be able to flow around the body. You don't want the blood to be in a clotted state normally. But the blood needs to be able to turn into a clot when necessary. So when there's a vessel break, the blood needs to know to turn into a clot and do it quickly, but only then. And so we have these mechanisms in our blood that can turn the liquid blood into a blood clot. But we normally want to keep them turned off when there's not, an injury. So these hemostatic mechanisms need to be kind of very, very carefully balanced so that they're ready to get triggered when they're needed and triggered very quickly, but they don't get triggered when they're not supposed to be triggered. You don't get a clot when you're not supposed to. You don't get a clot in your vessels, and so there are people who have problems where their hemostatic mechanisms aren't active enough, and they're prone to excessive bleeding, and they have in danger of death from that reason. And then there's plenty of times when people have overly active hemostatic mechanisms. They get clots formed in their blood vessels. They get blood cut off basically to their vital organs and can die. Or you get a blood clot in your leg, and that blood in the vein of your leg, and then that clot breaks off and goes and blocks blood to your lungs or something. So these imbalances are really common and dangerous. Hemophilia is the general term for people who bleed too much. Hypercoagulability is people who clot too much. And we see both ends of that spectrum all the time in the hospital. In fact, you can have one person be having sort of both problems at the same time. They're not clotting well enough in certain ways, but then they're making clots when they shouldn't be in other places in their body. And there are actually, and then there are inherited conditions that can cause hemophilia. So, you might have heard of families where hemophilia is carried in the family. And then, similarly, there are people who have diseases where they clot too easily. Some physiological conditions can also throw this off. So, pregnancy causes increased clotting, and pregnant women are at a higher risk for getting blood clots. Cancer also causes increased clotting. Okay, so clots, clotting process. How does it work? So, in fact, not even just, I shouldn't say clotting process, because clot is only actually one type of hemostasis. So let's say hemostasis, how does it work? And there's basically two phases. So, two phases of hemostasis. And the first one is something we kind of already looked at briefly, and that's platelet plug formation. And it's the first thing that happens when there's a vessel break. So, by the way, when I say a few phases of hemostasis, what I basically mean is responses to a vessel break. Okay, that's when you would want these things to happen. They sometimes can happen even when there's not a vessel break. So sometimes these processes happen just within the vessels and cause clots, cause hemostasis when you don't want them to happen. But this would be the normal physiological mechanism. You get a vessel break, and then you get these two processes. First, a platelet plug, and then the second phase was called the coagulation reaction, which leads to the formation of a blood clot. Okay, so platelet plug we've talked briefly about. We'll go into a little more detail now. So vessel break occurs. First thing that happens is platelets respond and form a platelet plug. As I kind of mentioned, platelet plugs are actually pretty much adequate for blocking off very small breaks. And remember how I mentioned how we get little small breaks all over our skin, all over our internal passages, like all the time. One of the ways you can see that, so people who have low platelets are obviously deficient in making platelet plugs. And one of the things you can look for to see someone if they have low platelets is to see that they have basically little tiny bleeds all over their body. So they get them all over their skin. They also get them, if you were to put a scope down and look down their esophagus and into their stomach, you'd see pretty much the same pattern you're seeing here. And so these little bleeds are generally referred to as petechiae. Basically just little bleeds into the tissue. Larger ones are sometimes called purpura, but we'll just call them all petechiae. That's the more common term I've heard. When if you were to see a patient with this, what you want to think is that they're not making platelet plugs appropriately. The little minor traumas that all of us sustain are causing this person to get little tiny bleeds when normally they wouldn't, because they'd have platelet plugs. So they must be low on platelets, or they're probably low on platelets. Okay, so let's talk about platelet plug formation and the steps involved. Okay, so we start, our picture sort of starts over here with a platelet floating in the blood. That platelet then encounters an area of broken vessel. And the key is that, here, these guys are, the endothelial cells, right? These are the cells that line the vessel wall. Endothelial cells. These are the cells that normally the platelet would only ever see the endothelial cells. But now there's a break, and so the platelet can now see the molecules that are found in the tissue beneath the endothelial cell. And so, like, one of the molecules that the platelet can now see is collagen. Normally it can't ever see any collagen. And it turns out platelets actually have kind of little receptors on their membranes that can detect collagen. And when they detect collagen, so some of this collagen actually gets shot up into the blood. When they detect the presence of tissue molecules like collagen, that triggers them to do what's called adhesion. So this first step is called adhesion. And so platelets adhere to the location of the break and adhere to the tissue molecules, and they do that in response to basically detecting those tissue molecules. Okay, so that's the first step of platelet plug formation. Let me kind of erase these little arrows. It doesn't get confusing. Okay, second step. So once the platelet adheres and basically binds, recognizes collagen, that actually has the effect of what's called activating the platelets. So the second step is called activation. The platelet gets activated, this guy gets activated, and what he does when he's activated is he releases signaling molecules, and don't worry which molecules those are. But what those signaling molecules do is they go out into the blood, they are recognized by other platelets, those platelets now get activated and come in and join the party, and they come in, bind to the tissue or bind to other platelets. And so leading to the third and final stage, which we'll talk about in a second. But so one of the things I want to point out here is that so say we start with an intact vessel and the platelets sort of quiet. The initial break occurs. Say a couple of platelets come and bind and get activated. Those platelets now send out signals that recruit a whole bunch more platelets, and these platelets in turn release more signaling molecules that go and attract more platelets, etc., etc., etc. So this is this process starts with a quiet platelet, nothing activated, and then as soon as there's a little bit of activation of the platelet, a couple of platelets, those guys send signals out that activate a whole lot more platelets that then cause even more platelets to be activated, et cetera, et cetera. So this is a very clear example of that process that we talked about, where just starting the process, just sort of triggering the initial change causes the process to build on itself very rapidly. So we call that positive feedback. And it's good for making things happen very rapidly, going from one state to another. And in this case, you go from quiet platelets to a whole bunch of really activated platelets, making this platelet plug. So positive feedback is really important. It plays a big role in general in hemostasis. And so here's one of the ways. So in platelet activation and platelet plug formation involves positive feedback in this as we talked about. So, and then the final stage, then basically the final step of platelet plug formation is all these activated platelets basically stick together in what's called adhesion. So the different activated platelets are able to stick to one another. And there's an interesting molecule involved here that whose name will come back to us in a minute, called fibrinogen. Fibrinogen is actually used to basically form the bridges between these activated platelets. It's how they connect to one another. So in this platelet plug, you have a bunch of platelets connected together by fibrinogen. Fibrinogen is a molecule that just floats around in the blood, and the platelets use it and grab it basically and use it to connect to one another. So in the platelet plug is a bunch of fibrinogen, because that's what the platelets are using to connect together. And we'll see that platelet fibrinogen can have an important role in the second part of hemostasis, specifically blood clot formation. Okay, so I think I'm going to stop this video here, and I'll talk about blood clot formation in the next video.